Hello. Okay. Today I would like to share some of our experience cases. It's about communication regarding to the neuroendovascular procedure. And this is some of the mention I would like to tell before the presentation. Here we just want to show all of you about the sharing the knowledge and some of our personal cases and some of our friends. It's not a legal document to use for any wrong purpose. And actually, it's not accuse anyone for showing the procedure. And I don't want to make any trouble because using for the imaging to show the other one. And please respect our patient because some of the patient have passed away after the complication. And where the complication, we know that the knowledge is very important, including the anatomy, physiology, and diagnostic and treatment. It's very difficult to make sure that we cannot make any mistake for the patient. And the second will be the skill. The skill of the neurointerventional is very important. What about the learning time and experience for perform for the doctor who have performed only few cases will be totally different with the man who perform thousands of cases of experience. And we need to consider about the medical ethics, indication, and the way to treat with the harness to the patient. Some of the using of the device, the implant, wrong indication can cause the major problem of the complication. And especially I would like to tell some of the patient has a very difficult characteristics because nobody has the same anatomy, especially we don't know before the procedure. And some patient has allergies, especially for some of the reaction we don't know before procedure. And some of the trigger from the medical equipment, like using the angiography, the cath lab, the ventilator, and many things to affect to the result of the treatment. And the diagnostic can be cause the major problem also. And this is the case. Our colleagues perform the diagnostic cerebral for the patient with the bleeding, and we see that's a very tortuous vessel. And this is after the procedure, the patient on the table but feel weakness on the other side, and maybe related to the dissection of the internal carotid artery. During the procedure, we go back to the other side to check the dissection of the vessel here. In this situation, we don't want to treat, we don't want to do the stenting, but we have to do something for the patient because the patient had a symptom on the table during the procedure. And this is the way to treat, to rescue the carotid artery. We navigate with very far away, very difficult to get through the dissection point, and we dilate with the balloon. And after that, we have to deploy the stent to protect the vessel not to collapse again. And this is emergency stenting procedure. And this is the stent we use, and this is the final result. We reserve the carotid artery during the diagnostic procedure. So it is very important to understand. Sometimes we just do the diagnostic for the patient, but we can cause the major problem, and we need to explain to the patient, we need to do stenting and whatever. Just only before procedure, we explain the patient just do something for the diagnostic, and after that, the patient has to pay a lot of money or whatever. They can ask the doctor a lot of things. And for the neurointerventional procedure, the major problem, the complication, mostly regarding to treatment of neuro aviation is more difficult to the other, and make the sometimes we make the communication without any respect before. And this is the way to treat for the neuroarteriovenous fistula. We can perform the treatment by trunk arterial approach, BVA and glue and onyx injection, and trunk venous approach by using the fiber coil, bare latinine coil, and sometimes we use radial surgery to treat for the very low flow aviation, and sometimes the patient no need to do anything for the patient. With the very minor symptom and no hemodynamic change, we should not do anything to treat the neurofistula. Okay, this is the case. The first case we show you, the patient female has severe contraction of the eye, and we make a diagnosis. The patient has neurofistula on the left side. The first neuroendovascular procedure have performed and failed. After that, we send the patient to radial surgery. And this is the imaging after 2 weeks radial surgery with gamma knife. The patient went back to the hospital with more severe symptoms, even worse, more severe than before the intervention. Because now the patient cannot move, the patient has severe cerebellar syndrome and MRI, so edema, severe edema of the cerebellar, bilateral, and some congestion severe. And it is angle, the second angle, so that the patient still has the remaining neuroaviation, so we need to treat the patient again with the second attempt, the same way to try to go to close the fistula at the cavernous sinus. And this is the way we treat for the second procedure. We go to IBS and go to the ophthalmic gland and occlude the ophthalmic. Totally the fistula has eliminated. And this is the both procedure, and luckily because the patient improves very good result for this case, not major problem afterward. Very good experience. And this is another neurofistula case. The patient went to the hospital with very minor symptom. On the left side, the patient has headache a little bit and red eye and the left side. And this is the neurofistula from the both internal and external carotid artery, and come to the mainly to from the right side to the left side. And our colleagues, they perform the super selective, so very good hand to navigate to the ophthalmic gland, and this is the venous. And we treat the patient with coiling procedure, and very good result afterward, totally cure the lesion. But the day after the procedure, the patient has the severe symptom, coma, and malfunction of the pulse and deep coma afterward. In this case, we cannot do anything to rescue the patient. This is very severe complication. But why? For this case, why the patient has so severe? Because the anatomy point is so important. Some venous ran for the pulse and the base cerebellar ran to the cavernous sinus, where we close totally by the coiling procedure. And here another case, the patient has a normal variant of the venous. Some of the major brain running for the pulse and some of the cerebellar. When we try to close the cavernous sinus, we can occlude this major vein and cause a major problem, and the patient unlucky and pass away. And another procedure, treatment of aneurysm, we can cause also the complication with the FD treatment. I have bad experience, but I would like to share with you. This is here you can see here the aneurysm and weak point. But consider for this case above and below the maybe distal has another aneurysm. It's a very small aneurysm here, and below has stenosis. And we treat the case because the patient has two aneurysms, one distal and one here. So we treat the case with flow diverter. Choose a little bit long, but consider it's a stenosis at below the aneurysm. And this is after we deploy the flow diverter. Look good, but a little bit stenosis at the proximal. I don't want to make any trouble, so I stop procedure here and without the dilation of the proximal of the flow diverter. And 2 hours, about this is after stenting. We can go through the stent very smoothly. So that's why we don't intend to make any complicated. We stop procedure. The patient wake up well, and after 2 hours, the patient has problem, weakness on the right side, and we think about the complication. That's why we did the second angle to see, and we find it's occlusion, intra-stent occlusion. It's very major problem for the patient. That's why the patient has coma, and we try to rescue the patient for this case. The first procedure, we navigate the microcatheter like normal to across, go inside the stent and across to the distal part, but fail. I can tell you, when we deploy the flow diverter, it's very difficult to enter, especially the stent has very long, and sometimes it's with the stenosis at the proximal. We cannot enter to the lumen, and for this case we try many times but cannot. And when the wire across to the distal part, and so we cannot put the catheter forward, follow the guide wire. And unfortunately, we caused the major problem by bending the stent and migrate the stent to the aneurysm at the proximal part. It's very major. And you can see here like this. You can see here, we try to go with the microcatheter, but it falls into the aneurysm. And you see that we cannot expect what happened. And you can see very clear the patient has the stent proximal enter to the aneurysm, migrate to the aneurysm, and totally deploy, totally open, and get struck, close the point to enter the carotid artery at the distal part. It's very difficult. We don't know how to go through the stent to dilate, and then we try many kind of procedure. Even we go with sub wire, go to the distal part up to M3, but the microcatheter cannot follow. And we think that we try something more steep. That's why we choose the gateway balloon to follow the micro guide wire. You will see. With the support from the gateway balloon, we can go to the distal part at M3, and we try to dilate the stent. Try to dilate the flow diverter to compress the stent and make it a little bit lower. And here you will see we try to dilate the stent to compress the flow diverter with the gateway balloon. And luckily we can do that. We can move the stent a little bit lower, because I don't want to try to cover all of the section, all of the part of the M1 with another stent. This is the picture. We inflate the balloon and we a little bit move back to get the stand lower, because I don't want to cover very long this segment. And we worry about the obstruction, occlusion and thrombus when we try to deploy 2 layers of the stand. But not the finish, so we think about how to treat the aneurysm. We use another stent, it's the wingspan, to compress the flow diverter. And the purpose is treatment of aneurysm, not the dilation, not the treatment of stenosis. So how to treat the aneurysm now? After we successfully deploy the wingspan, if we has another way, we has look at the another point to treat the aneurysm with the coil. Here, after we deploy the stent, the wingspan compress the flow diverter. You will see very nice picture, and the proximal of the stent totally enter to the aneurysm. And we coiling the aneurysm by gelling technique. It's not so difficult because the stent have the segment inside. You see that it's very easy now to coil, but we spend so many things: flow diverter, the wingspan, and the coil, and the balloon, many devices, material. But finally, we can rescue the patient. Very lucky. And this is the final result. Complication caused by the flow diverter, and actually not from the flow diverter, because the very difficult case, the patient has 2 aneurysm, and below the aneurysm has most severe stenosis. It's about 50 to 70%. And we deploy the stent. We didn't dilate at the proximal. That's why create the thrombus, and we don't know thrombus inside the stent can be occur without any explanation. And very lucky because we can across the flow diverter with the wire, and I recommend to use a little bit stiff microcatheter. If we can use the same kind of our procedure to use the gateway balloon to across the stent. And this is the final. We consider worry about the occlusion again, so that's why we try to dilate again to compress the stent again to the wall, and the patient finally has totally recovered. It's very good case to learn, especially for the skill of this case is major, because we have to know using the balloon, using the flow diverter, using gelling technique for dilation. And this is the final procedure: 2 stents, 1 stent compress the flow diverter and coiling and dilation. So the complication can be happen anywhere over the world, and can be happen with anyone. Nobody can say that I have no complication. So please, I would like to invite you for stroke summer school. By here we can learn more about the animal lab before we perform with the patient. And this is our email address. So I schedule to invite you for next year stroke summer school. And our center now currently is the reference site of Siemens Healthineers with the highest technology, including the robotic in the future. And we also achieve the platinum status for award from WSO for the stroke management with 1,500 cases per year can support you to train for neurointerventional procedure. Thank you for your attention.
Thank you, Dr.